Hello and welcome to our continued lecture on chapter 43. In this video, we're going to talk about the inflammatory disorders of the skin and papulosquamous disorders and vesiculobullous diseases. So we'll start off with the inflammatory diseases, first on eczema and dermatitis, which are used interchangeably and are the most common inflammatory disorders of the skin. We see that people that have this disorder have pruritus, lesions that have indistinct borders, and some changes to their epidermis. And the lesions can vary. They can be erythema, papules, or even scales taking place on the skin. And if it gets chronic, then the skin becomes thick and leathery, which is kind of what we see over here. And it can be hyperpigmented, whether that is through the redness or it could be a darker shade as well. Another type of dermatitis is allergic contact dermatitis, and this is due to T cell mediated or a delayed hypersensitivity reaction. The allergen comes in contact with the skin. Both of the examples here are coming into contact with poison ivy, and then the allergen binds to the carrier protein to form a sensitizing antigen. The Langerhans cells within our skin, also known as the dendritic cells that we're going to find in that stratum spinosum layer of the skin, are going to process that antigen and then carry it over to the T cells, getting them to trigger that alarm and become sensitized to the antigen. Now, we use the example of poison ivy here, but it can also take place in reaction to certain microorganisms or chemicals, foreign proteins, latex, drugs, or metals. So once we come into contact with those allergens, it could be several hours before we actually see a apparent reaction taking place. And once they do, we may see things such as erythema, swelling with pruritus, especially if we have vesicular lesions like we see on these images here. And where we see those vesicles form gives us an idea of what it could have been that irritated that area. Next, we have irritant contact dermatitis, and this is caused by the activation of our innate immune system, which, if you remember, is non-specific. So this could be related to the concentration of the irritant, the length of time of exposure, and the disruption of the skin barrier. An example here is of somebody who is wearing a ring, in which we see the irritation to the skin or the dermatitis taking place here. If you remove the source of irritation, and you may even use some topical agents, you can effectively treat this. Next, we have atopic dermatitis, and this is also called allergic dermatitis because we see that it's associated with IgE antibodies. And we see that it's more common in people that have a history of the hay fever or asthma, and they'll typically be more affected in infancy and childhood, but some people are affected throughout their adulthood. Another inflammatory disorder is stasis dermatitis, and this occurs in the legs as a result of venous stasis and edema. So really within people that have varicose veins or phlebitis or vascular trauma, in which we have a pooling of that venous blood, and that tends to trap the neutrophils that can release oxidants and proteolytic enzymes. This then widens the interendothelial pores, and we get red blood cells that get deposited along with fibrin and other macromolecules that make them unavailable for any type of repair and promotes inflammation. So some clinical manifestations are erythema first, then we get some pruritus, then some scaling, petechia, hyperpigmentation, and ulceration, especially in the areas of the ankles and pretibial right along the shins. Pictured here, we have seborrheic dermatitis, and this is a chronic inflammation of the skin that involves the scalp, eyebrows, eyelids, ear canals, and here we see in the nasolabial folds within the axilla, chest, and back. It is represented as cradle cap within infants, where you'll also see some flaking taking place in the scalp, and you could see it is of white pigmentation, or it could be a little bit yellowish, which we see in the corner here. And unfortunately, the cause of this is unknown. But there are many types of treatments. I know for my daughter who had cradle cap, I just used coconut oil and that seemed to do the trick. But there are some topical therapies also that include antifungal shampoos, calcineurin inhibitors, and low-dose steroids for acute flare-ups. Now we're going to start into our papulosquamous disorders, starting with psoriasis. This is a chronic relapsing proliferative inflammatory skin disorder. It's caused by a complex interaction between the macrophages and the fibroblasts, our dendritic cells, the natural killer cells, T helper cells, and our regulatory T cells. So we can see that involvement in the schematic here on the right hand side. There may be certain environmental stress triggers that affect our keratinocytes that then are going to release certain chemicals to activate our dendritic cells, which then secrete IL-23, and that affects our regulatory T cells, which then continue to secrete their own chemicals. And what we get is epidermal remodeling and the plaques to form. So we get dermal and epidermal thickening, and essentially the epidermal turnover goes from between 14 to 20 days to 3 to 4 days. Our cells don't have enough time to mature and adequately keratinize, and they end up getting this silvery appearance. So you can see there's many different forms. This one is our plaque psoriasis. We've got inverse psoriasis, which is rare and typically develops in areas where we have the skin folding, such as the elbow that we see pictured here. It could be in the axilla or the groin. We have guttate psoriasis, which is when we have these small papules on the trunk and extremities, and this tends to pop up after a streptococcal respiratory tract infection and then disappear within weeks or months. Our other type is going to be our pustular psoriasis that appears as blisters of non-infectious pus. Then we have our erythrodermic psoriasis. It's represented with red scaling lesions, and typically it is itchy as well. And down here we have pictured our psoriatic arthritis, which typically affects the hands, the knees, the feet, and the ankle joints. And lastly, our psoriatic nail disease, in which we may get some pitting taking place, onycholysis, subungual hyperkeratosis, and nail plate dystrophy. Our next condition is pityriasis rosea, and this is a benign self-limiting inflammatory disorder that typically happens in the winter months. We believe that this is due to a herpes-like virus, possibly human herpes virus 6 and human herpes virus 7, and this condition starts out with what we call a Herald patch. It is a bit circular, demarcated, and is a salmon pink color that is about 3 to 10 centimeters, and this tends to pop up in the area of the trunk and look more like a macular or papule. But as time goes on, secondary lesions start to develop within 14 to 21 days and extend over the trunk and upper part of the extremities. Rarely will be in the area of the face. And I threw this picture in here to give you an idea of what takes place over time, where these smaller spots then start sweeping out from the middle of the body, and it starts to look like a drooping pine tree. Our next condition is lichen planus, and this is a benign autoimmune inflammatory disorder of our skin and mucous membranes. The cells that are involved in this are our T cells, and then we also have our adhesion molecules, inflammatory cytokines, perforins, and the antigen presenting cells. So like your macrophages, your dendritic cells, and sometimes B cells. Unfortunately, we don't know the cause of this disorder, but it is linked to several drugs and hepatitis C virus. It begins with this non-scaling purple-colored, flat-topped polygonal pruritic papules that are about 2 to 4 millimeters in size. So you can see they're quite small. These are a little bit larger in I wanted to represent this with a darker skin tone, but we do tend to find these in areas of the wrists and the ankles and lower legs, and also the genitalia. We can also find some lesions in the oral region that appear to be a lacy white ring. So sometimes it can be mistaken for things like candidiasis, and they typically don't ulcerate, but they can occur at times and be very painful. And patients with this disorder tend to say that the pruritus or the itching is the most distressing symptom, especially since this can last for months or years. Next, we have acne vulgaris, which is an inflammatory disease of the pilosebaceous follicles. Essentially, we're talking about how the sebaceous gland has a relationship with the hair follicle, and when infected, it can cause inflammation in multiple areas of the body. We're going to talk about this more in chapter 44. Then we have hidradenitis suppurativa, and this is also known as inverse acne. It too is an inflammatory disease, but it's of our deep sections of the apocrine glands. If you remember, the apocrine glands are sweat glands that are associated with hair follicles. So we tend to find them in areas such as the axilla or the anus or the genital area. And it could be complicated by fibrosis and draining of sinus tracts. And this tends to happen in women more, although we're not sure what the cause is, but there seems to be some type of genetic predisposition and there being some type of altered immune response. We could see some of the lesions presented over here. It is a deep, firm, and painful subcutaneous nodule that is associated with sinus tracts. These can rupture horizontally under the skin, so you could see that may have taken place right along in here where the fold of the axilla is. And the best way to treat this is to have some type of topical therapy, systemic medication, and an incision if necessary to drain any nodules that are present. Next up, we have acne rosacea, and this is an inflammation of the skin that develops in adulthood. There are 3 types that are having to do more with the skin, and then the 4th type is affecting the eye, so that's ocular. So the first type is our erythematotelangiectatic, and that deals with a redness or maybe a development of the capillaries around the nose and around the cheeks that we see pictured over here. The second one is the papulopustular. So that tends to have a little bit of more vesicle looking like structures going around the bridge of the nose and then a bit underneath the eye. So you may think you have acne, but it's not really acne, it's rosacea. And the last one is our phimosis, which is going to involve more nodular looking like structures on the nose. Now, the exact cause of this is unknown, but there may be some genetic factors or immune dysregularity that is affecting the body to cause this reaction within our skin. And there are some things that can trigger flare-ups, such as sun exposure or consumption of alcohol or coffee, things like that. There may be changes within your hormones that cause it to come about as well. Now, if the person has neurovascular dysregulation taking place, though, that is associated with chronic inappropriate vasodilation that results in a flushing, which you can see a little bit of flushing in this person's skin, and it could cause a burning sensation and sun sensitivity. So it's important to protect your skin by wearing sunscreen, a wide-brimmed hat, and avoiding other triggers, like we said, alcohol, for example. Next, we have lupus. I won't spend too much time on this since we've already talked about this in chapter 8. But this is a systemic inflammatory autoimmune disease with some cutaneous manifestations. That's why we are talking about it here. So specifically, discoid lupus erythematosus occurs in genetically susceptible adults and is restricted to the area of the skin. Women are affected more, and we see it more within their late 30s or early 40s. And the lesions within this condition can vary in size. You could see some taking place on the forearms over here. And they may be single, they may be multiple, so it just depends on the person. But the lesions are located on light exposed areas of the skin most of the time, and photosensitivity is common. We, of course, have seen pictures of that butterfly pattern over the nose and the cheeks, and these lesions can stick around for months and then resolve spontaneously or atrophy. The last big topic we're going to talk about in this lecture is the vesiculobullous diseases. So the first one is our pemphigus, which is a rare blister-forming disease of our skin, and it affects the oral mucous membranes. Pemphigus vulgaris is the most common form, and it's caused by circulating autoantibodies that are directed against the desmosome adhesion molecules within our epidermis. If you remember that layer of our epidermis that's called the stratum spinosum, it was known as the spiny layer because it looked like the keratinocytes had spikes coming out of them, but really they were the desmosomes. And so we lose that adhesion and it causes fluid accumulation, and we get these blister or bullous formations on the skin. Now, there does seem to be some type of genetic predisposition to this, but there may be some environmental factors at play as well as endogenous, such as emotional or hormonal stressors. The other disease we're going to discuss is erythema multiforme, which is a syndrome characterized by inflammation of the skin and the mucous membranes, and it's caused by an immunologic reaction to drugs or microorganisms such as herpes simplex virus that is going to target the small blood vessels within the skin or the mucosa. What is pretty distinctive about this is that it forms a bullseye. You could kind of see this one is probably the best example of it, a bullseye or a target type of lesion with a central erythematous region surrounded by a concentric ring of alternating edema and inflammation. And these lesions suddenly occur in groups over a period of 2 to 3 weeks. And we can also develop other lesions that don't have the target look to them. So you can kind of see these on the other side where they don't have that target appearance. And these tend to be more on the extensor surfaces. So here's the back of the forearm and here's the back of the hand. Although, yes, in this picture, we are seeing the palm of the hand. We can also see other areas being affected, such as the mouth, our air passages, esophagus, urethra, and conjunctiva. Next up, we have the Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, or TEN10. This is the same disease at different points on the continuum. So to differentiate them, we look at the clinical presentation and the severity, but both of them are going to be type 4 hypersensitivity reactions to drugs and our medical emergencies. So first, we start to see these patients have fevers, headaches, malaise, a sore throat, and cough, and develop bullous lesions that can then form erosions and crusts when they rupture. As far as the mucous membranes that are affected, that includes the mouth, the air passages, the esophagus, urethra, and conjunctiva. Blindness is possible due to corneal ulcerations. They may also have difficulty eating and breathing and urinating because of the effect on those mucosal passages. So once we realize that this patient is having these symptoms, we want to get rid of any ongoing drug therapy that is taking place and reevaluate them and treat any type of underlying infection. So the easiest way to tell the difference between SJS and TEN is that within SJS, we will see less than 10% of the body surface area is involved, whereas in TEN, we're going to have greater than 30% of the body surface area involved.